Hello, and welcome back to another episode of I See You. Today, we are going to be talking about endometriosis and how to get relief from that. And to help with this conversation, I have Jill Mueller with me, and she is going to share a lot about her journey and what she's doing now and how she's helping other people. So, welcome, Jill.
Thank you so much for having me. I feel honored to meet you off of social media and in person, and I think we're speaking the same language, so I like it.
We're on the same wavelength for sure. Can you take a minute and introduce yourself to my audience? Like, who are you? Where are you from? What do you do? That type of stuff.
Yeah, so I am currently living and from Canada, so I'm in Ontario, Canada, and I, as a profession, am a physiotherapist. I shifted into pelvic physio and pain science because of my own journey with endometriosis, of which I discovered through 10 years of fertility and trying to get pregnant. But I did have the classic signs of period pain, like debilitating period pain. In fact, I gave birth once I did get pregnant without pain meds in order to see if it was like my menstrual cramps, because I always suspected they were similar, and it was, except I was getting something out of it this time. But I took a pain science course for my patients, and like just thinking it was for them, and didn't realize that I was somebody who had chronic pain or persistent pain. I like the word where it's going now because it sounds less permanent. But I implemented a lot of the strategies surrounding sensitization that I was actually experiencing. And that drastically changed my pain. And then I took another course, a trauma course for my patients, not trauma course, a trauma course for my patients. And again, I didn't realize I was somebody who had trauma, and realized that was a component of it. And through that course, got myself actually out of period pain entirely. So I had surgery, but it wasn't the right surgery. And we can go into that if you want. Didn't really do anything for my getting pregnant at the time, wasn't right with the right person. But switching to addressing the pain and using pain science techniques, that's what really made a difference to my quality of life, which I think is
Okay.
a similar story for you, right?
Yeah, for sure.
Yeah.
It's funny how many people I talk to, like with the same story of you have this personal connection, and then you realize that the what you're learning actually can apply to you, and it can also help your clients. So it's, a two for one
Win-win.
win. Hmm.
Yeah,
Exactly. So I'd love to dig into your story a little bit more if that's okay. Like, when did
absolutely.
you start with symptoms and what were they? Can you get specific?
So I can't remember if, so I was kind of a late bloomer in terms of period. I think I was like 15, 16, grade 9 or 10. I don't remember if I had period pain right off the bat, but if it was early on, if it wasn't right away. Now, the kicker was my dad was a doctor, and bless him, but it was like, well, yeah, period pain is normal. And this is a typical story we hear with my patients, with people with endometriosis. They're being told that period pain is normal. Now, some element of discomfort can be, but if you are not going to school or not going to work because of it, which I was anyway, I was one of those people that just kept going and ignored like all the signals of just slow down and maybe take it easy. But basically, I would battle through it every month. I think from the get-go, pretty close.
Yes. I think a lot of people or a lot of women struggle with knowing, like, is my period pain normal, or is it a normal amount, or is it un or not
Yeah.
normal because for me, like, I always had like really bad cramps, and then, I went on birth control and still had some cramps, but it was fine. And then I came off of it about 2 years ago, and it's kind of back, but it's nothing like yes, I'll take maybe a Tylenol or something, but it's not like keeping me bedridden. So, can you talk about like what is normal versus what isn't normal in terms of pain?
Well, just to kind of use your story as an example, I do wonder if because of the bladder symptoms, were you having them at that time too?
I had bladder symptoms until I was 25, and then I went off birth
So
control like later after that.
so I find that when they're kind of like we've got the bladder in the front, the uterus in the middle, and the rectum in behind, and then the pelvic floor underneath. And they're like quadruplets. If one gets cranky, all of them can get cranky, or maybe one of them gets cranky. This is called cross sensitization. So if your bladder was if your brain was overprotective about your bladder because it was giving you distress, when the uterus comes in and it's trying to have a period, your pelvic area is having more stuff happen, and your brain is going to be like, I need to protect even more. And it will give you kind of that. So even if you don't have endometriosis, the uterus could have been sensitized because of the bladder being sensitized, right?
Yeah.
So yeah, I think the classic definition of what's normal and not normal is probably going to be, is it drastically impacting your life? Like, are you having to, like, to your point, stay in bed? Like, that's debilitating. If you cannot, take an Advil or a Tylenol and just kind of go through the day but be okay, then that's not normal, right? Even
Okay.
taking medication, I would say, is could potentially be considered not normal. But if you're changing your life and having to not go to work, not go to school because of it, definitely not normal. Doesn't mean you have endometriosis, but it is a classic symptom that should probably be investigated more.
I think it's so normalized in our society. It's like, oh, yeah, you have pain. That's normal.
Yeah,
And then
so
it's like,
this will delay the diagnosis, right? And then
right,
we become more sensitized because we're ignoring it a little bit more.
right. So you had the pain. Did you have anything else going on that was indicative of endo or aligned with that?
I mean, when I started to try and get pregnant, I couldn't get pregnant. I didn't even know what endometriosis was until I had a laparoscopy, that little keyhole surgery, and the fertility gynecologist diagnosed me with having a lot of endometriosis. It wasn't the right surgery. She just was trained to be able to burn it off, which is called ablation. You need to be able to do ablation on certain tissues that are more vulnerable, but you really want to be with a doctor who has minimally invasive gynecological surgery, MIGS trained, because they can do excision surgery, which is, if you imagine like an iceberg. So you know how above the water line there'll be some iceberg, but then below there's like a lot of iceberg. It's sort of like the analogy of them taking off. Ablation is like taking off the top of the iceberg only, and excision, you want to get the root or the whole thing underneath also taken out. Sort of like a cancer. I don't want to compare it. A lot of times people compare it to cancer. It isn't a cancer. Endometriosis is not a cancer, but we want to get rid of it from that standpoint where you're getting out the root, and then the chance of it coming back is less.
Sounds like pulling a weed in your garden.
Yes, exactly.
Okay, so you had some infertility issues.
Mhm.
Anything that had to do with like having a really heavy flow or anything like that? Because I hear about that a lot.
Yeah, so I was actually the opposite. I had barely any flow. And I remember being in my 20s and thinking, this can't be normal. Like my period was like really intense sensation wise, and not a lot of blood came out. Now, apparently, I have an abnormal uterus, but I actually wonder if I have adenomyosis, which is okay, so just to distinguish the definition of endometriosis and is when we have cells that are similar to the lining of our uterus but not the same, are found outside of our uterus, primarily in the pelvis, but has been found literally everywhere else in our body, in our brain, in our eye. Very rare. Wrist, joint, like very, very, very rare. But they have, my point being, it's not just a pelvis issue. So it shouldn't technically be dependent on a gynecologist only to deal with it um medically. I don't know who is going to. That's an area that needs to blossom in the medical system. Now, adenomyosis is, let me go back to endometriosis. The way it's similar to the lining of the cells in the uterus, the lining of the uterus and the cells there, is that it will respond to hormonal changes. So those little endometriotic lesions or cells outside in the pelvis, when it notices these hormone changes, it will start to bleed as well and create a little inflammatory response. So, but the thing is, some people will have a lot of endometriosis and no pain whatsoever. So this is where you and I are going to get into that conversation. But when I heard that, I was like, how do I become one of them? That was the question for me. But that's the definition of endometriosis. Now, adenomyosis, which we can have both. Adenomyosis is not endometriosis. So you can have adenomyosis without endometriosis, or you could have both. Adenomyosis is when there's the normal lining of the uterus, and normally it sheds every month, is starting to grow into the muscular layer of the uterus. So on now, technically, the only way to diagnose it is after it's taken out of you, so a hysterectomy and like sent to a lab. But on ultrasound, some trained radiologist or sonologist or whoever's doing it, it'll look like a bulky uterus, a bulky uterus. So now the classic signs of that are really heavy bleeding. I may have it and just not have the heavy bleeding. So anyway, it can create pain, but again, it's not painful in everybody. Just like all these other structural things we find, like Hunner's lesions and glomulations, and it's like so confusing because we can have, why do some people get pain and other people don't? And yeah,
Yeah,
so that's a
for
bit of
sure.
the conundrum.
The conundrum. Yeah. How long did it take you to get a diagnosis?
26 years.
It's a lot.
That's a lot of years. I know I only look 26, but no, I'm just kidding. It did take a long time. I think part of that is because my dad told me it's normal. So, like, I wasn't seeking out an answer, to be honest. I was like, I guess this is normal. And, like, just went on life until I tried to get pregnant. Even then, when she diagnosed me with endometriosis, okay, this is before the internet. Thank God, because if it can be a rabbit hole, sometimes it can be helpful, sometimes it can't. But I was so fixated on trying to get pregnant. I was like, okay, whatever that is. Like it was like a big disconnect. I was like, whatever that is. Meanwhile, it's pretty. She didn't explain much to me or at all, actually. Or if she did, I wasn't listening.
Yeah, I feel like that diagnostic process is tough because isn't the gold standard like the laparoscopy procedure?
It's changing.
Good.
So yes, this is where I'm so blessed to work with probably the leading person in this in definitely in North America. He is Dr. Matthew Leonardi. If people want to learn more, follow him on Instagram. He's Canadian, but he was trained in Australia. He did his residency for gynecology in Australia and had the opportunity to also do sonography, so ultrasound. And they were doing research on endometriosis with ultrasound there, which has come so far. So here's the thing. Actually the guidelines now are now recognizing it, like just new recent guidelines are recognizing that ultrasound and or MRI, although MRI can be expensive, MRI is great for extra pelvic symptoms. So if you feel like you're having trouble breathing or a lot of pain in your diaphragm during your period, like cyclical symptoms that are outside of the pelvis, the MRI can be really good for that because those are extra pelvic. Whereas the ultrasound, they'll do a transvaginal ultrasound or a pelvic abdominal ultrasound. Both of those depend on the training of the person who's reading the imaging. So if you have had an ultrasound or many ultrasounds at Joe Schmo ultrasound place, they're great for diagnosing endometriomas. Maybe we'll go into the different types of endometriosis. Endometriomas, they learn how to look for that. They learn how to look for fibroids and stuff like that. But when it comes to the nuances of endometriosis, they're not usually trained. So it gets missed a lot. So just because now, and this is for even trained people, if you don't see it on ultrasound or MRI, it doesn't mean it's not good at ruling it out, but it is good at ruling it in. But it all depends on the person who's doing it. So this is a massively growing area. He's starting to train people now all across North America. So more people are getting, usually doctors versus the ultrasound techs are getting trained in what to look for. So it's a big growing area. So that is the first line that they're trying to help people get diagnosed earlier, because if they can get diagnosed earlier, then they can get treatment earlier, and this helps reduce the chances of sensitization more. Like it's just all much more supportive, and you're not having to wait as long. Because also getting diagnosed, I had exploratory laparoscopy, but that's surgery. Like you're put under. Like people don't realize how invasive that is. Like just, like anesthetically, all these components to it, right? So while that can also be helpful, you want to again be with a specialist who knows what they're looking for, because some people have undergone a laparoscopy and it's been missed. Because if they are not trained to know what to look for, then they're going to miss it. And so you've had this surgery, they're ruling it out, or, but maybe it's their lack of knowledge of the area. So it's really important to be with someone who understands what all of the nuances of endometriosis, because traditionally they're kind of told in medical school, I think they're given like 20-minute lecture on endometriosis, and yet it affects 1 in 10 at least people born with a uterus. That's a lot of people. That's like 200 million people worldwide.
That's crazy.
Who are diagnosed, who we know of. So that's probably higher because we know it gets missed all the time. So diagnostic testing is less invasive and becoming more easily read. Like we can get into someone more easily. It still needs to grow, of course, but it's on its way. It's not where it needs to be, but it's on its way. Now I want to kind of go back to the different types of endo, if that's okay, because it used to be graded on scales, like a scale of 1 to 4, based on the amount there is, which can be helpful for them medically, but there is no correlation. Somebody to pain to someone's experience. So someone could have a lot of pain and symptoms and have very little of the disease, and somebody could have a lot of the disease and zero or very little symptoms. So there is no, just like many other things as we get into this line of work, we see there's not really a correlation between the findings structurally and what were our experiences. So we'll get into that at some point. But if we look at the types of endometriosis, there's superficial endometriosis, which is anything that is in a tissue that's less than 5 millimeters. Deep endometriosis, so that's like 80% of the people with endometriosis will have superficial endometriosis. Deep endometriosis is when it goes more than 5 millimeters into the tissue. That's like 20 to 30% of the people with endometriosis. Then we've got endometriomas, which are like cyst-like pockets of endometriosis, often found on the ovaries, but I've had patients that have had that on their belly button. They've been found in different areas of the body. Okay. And then extra pelvic now is being recognized. Extra pelvic just means outside of the pelvis. So if it's on your diaphragm or in your sinus cavity and your nose bleeds I put this on a post once and I couldn't believe the comments like, I have that. I have that. Your first sign that you may have endometriosis is that your nose bleeds every period.
Yeah, that's
That
a
might be
crazy thing to identify.
right. And nobody, even including doctors, might not be putting it together. They're probably like, oh, your nose is dry. Maybe you need to like put on a diffuser at that time or a humidifier, which could be the case. But let's look into it a little bit, right?
Right.
Yeah.
So after you got diagnosed, like diving back into your story, what happened then? Did you do any treatments? Did they help? What ended up helping you ultimately?
Um, so for me, because I was trying to get pregnant, I couldn't be treated like they treat people with not trying to get pregnant, because what they try and do is stop you from menstruating. But I needed to menstruate in order to try and get pregnant. So when you're trying to conceive, it can be really tough because you're not fitting into the typical first line treatment of it. And the first line treatment is medications that help alleviate the symptoms, and oftentimes like that's like the pill or Dianagest, these progestin based medications that can thin the lining, make you not really have a period, but not be designed to suppress the ovaries, but it does sometimes, like only a small percentage of people do ovulate on them. But then the second line of treatment is these more aggressive medications that actually put you into medical menopause, which I see in your line and my line of work as an opportunity to, when we can put out the fires, to build a base and a foundation for then when they come off those medications, that their nervous system is in a different spot and they're not feeling like they're in survival mode the whole time. With any of the medications, I do that. But the reality is, if we're put into medical menopause, you shouldn't be on that for a long time, and a lot of time, because it can affect our bone health, our cardiac health, and that sort of thing. You can do some add back therapy, which is hormonally just adding a little bit more estrogen back, but it's really got to be tailored to the person, is what it comes down to. They'll try and make it protocolish, but everybody reacts differently to different medications. And so, and medications isn't for everybody, and not everybody wants to be on them. So we kind of have to have another arena to help support them, which is what you and I are doing, which is what the medical system is not very good at seeing. And so this is where we need to kind of talk about this line of helping to support someone, especially to build a foundation for them. And especially if they don't have, like, can't be on the medication and don't want to be on it for a long time. We have to have a plan around it, is what it comes down to.
Yeah, for sure. Where are you currently at with your symptoms?
Gone.
I knew the answer to that. I just wanted to ask for everybody else.
Yeah, actually, the first time I had a period with no symptoms, it slightly freaked me out. I don't know if you experienced that.
The first time I had a pee that didn't burn, I was like throwing a party, just like a
But
one
isn't it
person
kind of
party.
freaky too?
A little. It's different. Yes.
I could feel it in my nervous system. Well, first of all, I was at work and I was working on someone and I was like, what is that? Like, I just felt this like drip. And then I was like, and then I went to the bathroom. I was like, well, now I don't have any. Can you give me a little warning? But I was like, that was so weird. Like, I've never had my period come. Like, I almost didn't trust it. It was a really weird feeling. It was like, there's no way that it's going to be like this forever. There's no,
I can
like, it's going to come.
imagine. Yeah, I can imagine how weird that must have been for you. Because, like, just thinking as someone who gets a period, like, yeah, there's usually signs ahead of time. Like, I'll get a little bit of cramping. Um, my IBS tends to flare up a little bit. So, like, I sometimes know it's coming, but I could see how that was a bit alarming.
Yeah. Yeah. I didn't know what to do with that information. I was like, okay, this is weird. Um, and then it got to the point where, you know, I wasn't getting pain with my periods, except the period after a girl's trip away. So
Interesting.
the reason I like to pull this or bring this up with people and my patients is because when people talk about stress, it's like that I would not have attributed to being stressful. But if you look at a girl's trip, it's stressors like I'm not at home, I'm eating different foods, I'm probably drinking too many sugary drinks, up late, not sleeping as well. Like, did I, if you said to me, were you stressed? I was like, no, I had the best time ever, but my routine was off and there were stressors like not sleeping and stuff that were slightly inflammatory that threw my system off a bit. I did eventually get to a point where I could go away on those girls trips and come back and have a normal period. But in the beginning when I got rid of, like, every month was fine, it was almost because it was because everything I was doing was like anti-inflammatory and lined up and like I was doing everything right, quote unquote. And then that threw my brain into like, what the heck just happened mode. And it didn't like that. And it was inflammatory and thought it was a negative thing. And so gave me pain that next period. Like, so much so where I would be like dry heaving on the floor. Like, but I wasn't scared. I was like, I know I got to get back on track. There was no wiggle room though until I took that trauma course and learned how to do things to kind of give my nervous system more wiggle room, expand my window of tolerance so I could do all sorts of things and it didn't see it as a threat. Like, I didn't have to be so rule oriented about. That's like what I find a lot of people do, right? They get into their window of tolerance. They're like, okay, now I don't get pain, but we want to, if your goals are outside of that window, we want to do something to build your capacity and resilience to build that window of tolerance out wider.
Right. It's like when people are like, yeah, I have my symptoms managed, but I'm following a strict IC diet. I'm taking medications. I'm taking all these supplements. It's like, that's great that you have relief, but there's going to come a point where you're going to want to have a cup of coffee or have a drink with friends. And
Go
if you could,
travel.
yeah, if you could expand your window of tolerance, then you'll be able
Yeah.
to do that without having symptoms. Or
Yeah.
you can get symptoms and not freak the heck out about them.
Yeah. So I almost say that to patients, like, we want to put out the fires, get everything, get your nervous system back into your window of tolerance. And then we want to work to build that window of tolerance back out to so that your goals, because it's oftentimes their goals and their or their life demands are outside of that. And so you want them to be able to work towards being able to work out or going traveling or going out with friends, like you're saying, right? Yeah.
Yeah, I can relate to what you said about the girls' trip. When my symptoms were present, I would always flare when I went on vacation because I wouldn't
Mhm.
drink like any water. I would wear like, I don't know, different clothes, like maybe like jeans or jean shorts or like a bikini. And that's not very comfortable to me. We ate different food. You're in the car a lot. Like, yeah, there's a lot of different things happening. So I know that there's like a group of us that symptoms did get worse with vacations, but there's also a
Mhm.
group of people whose symptoms completely disappear when they're on vacation. And that's like a huge flag for neuroplasticity.
I think that's a great point that sometimes vacation amplifies it. Sometimes it that it's just is it different when you're in a different environment. That is a good point because everybody thinks, oh, vacation, relaxation, not necessarily the point for everybody.
I was not relaxed on vacations as a kid.
Yeah.
It sounds kind of sad to say out loud, but we went on very wonderful vacations. But I was just thinking about my bladder the whole time.
I think with that's really common with bladder. Really common. Yeah.
I also was diagnosed with OCD as an adult a couple years ago, and looking back, I'm like, I was definitely like making
Mhm.
this worse with my obsessive thoughts and
Yeah.
compulsions. I mean, going pee like just in case, I feel like that was sort of a compulsion for me in college.
Well, and it's all the you had this sense of loss of control. Like you were taken out of your environment where it was predictable and you could manage the predictability. And if it's not predictable, that can really throw people's nervous system off. Yeah.
Totally. So do you consider yourself healed from endometriosis? What term do you
Uh,
use?
you know what's weird? I never felt unhealed. I think that's a big component. I think there's too much information out there now. It was kind of nice when you didn't have the internet and you couldn't look things up and hear what other people's experience was. Um, so that is, I have never been asked that. And I really don't like when people say they feel damaged. I'm not healed. I'm injured. And I'm like, I don't really identify with that, which I think is either denial or or healthy. I have no idea, but it seems to be working for me. I do know that if you feel like you're not healed and you're injured and you're damaged, that is a definite catalyst to the whole nervous system, immune system, everything's going to get amped up to try and heal you. Do you see where I'm going with that?
Hmm.
Right? So not that you can't unthink that. You can't unthink it. I don't want people to think this is all in your head. It's not all in your head. But if your core belief is that you have a disease, I don't even like that word for some reason. Because if you believe, I mean, you have a disease and you're not crazy for believing it. I don't want it to sound like that, but your immune system is 100% going to be constantly revved up for every amount of like inflammation that that senses. um like I kind of would love to see if we there has been a lot of research, not a lot of research, but research done on people who have endometriosis and no symptoms and endometriosis and symptoms. They've done brain functional MRI on the brains of people with endometriosis with no pain and people with endometriosis and pain, and we can see there is a difference. The brain in people who have pain is much more active, which makes sense. But the purpose of of that study was to see, is it the disease, not the disease, contributing to this factor of pain. So we know that it isn't, which is why we can have a lot of the disease and no pain. Okay. But I would love to see a study where they test inflammatory markers, because endometriosis is known as a systemic inflammatory disease. But I actually wonder, is it in the people who have it but no pain?
That is an interesting thought.
Right?
Yeah, I'd be curious to see that too.
And then, so then is, if there is inflammation, so then can we have inflammation and it in itself is not seen as a, like, nociceptively, like, activating our pain messages back up to the, like, I'm just so curious about, I am a clinician, not a researcher, but because I treat mostly endometriosis, I think of this stuff
I mean,
with my
same. I'm
patients.
like, can we please study this? And it's like, I mean, I took a course in college on research, but a lot of that has escaped me. And so I'm like, I have these ideas. Can somebody help me like
Yeah.
take that idea and study it?
Yeah, I know. So much research is so hard. There's so many components you can't, you have to like you can only study one component so at a time. So this is where I'm like, can we look at just inflammation? Can we challenge that definition of it being a systemic inflammatory disease, in the sense, like, is it for everyone who has endometriosis, or is it different for the people who have endometriosis and no, is their immune system optimized to be able to take up that inflammation, and it is the inflammation that's driving the pain, right? I don't know. That's my
Yeah.
curiosity.
I ask questions like that all the time, but do they go anywhere? I don't know. But I'd love to I'd love to dive into the physical findings and like pain science behind it all because I just published that episode with Dr. Howard Schubiner, and we were talking about, physical findings like Hunter's lesions. Do they
Yeah.
automatically mean like that's what's causing your symptoms, or can it be neuroplastic? And I'd love to hear your take on this topic with endo.
Okay, first of all, I'm so excited for his book to come out. I can't wait till it comes out, because he talks about pelvic pain, endometriosis, like all the parts that I treat. So I'm intrigued to see what his new book, May, can't wait, comes out and talks about. Um, so yeah, like I mentioned, you can have endometriosis and not have pain. The way sometimes it's discovered is people are trying to get pregnant and have so we do know that it can interfere with physiological symptom, like physiologically, like maybe it's all around the bowels and people can't pass stool very easily. Maybe it's all around the fallopian tubes, or it's affecting ovulation, and therefore when someone's trying to get pregnant, like the egg is not going down the fallopian tube. Maybe like physiologically, there may be restrictions in that happening. Maybe it is inflammation in the tubes, and that's not affecting them on a pain level, but it is affecting them on a physiological level of trying to get pregnant. I think any and all of those are possibilities. But just like disc herniations in the back, or bone on bone arthritis, we know that a radiologist cannot tell by looking at all of these scans of people with disc herniations and arthritis who has pain and who doesn't have pain. So there's more and more evidence to show that we can have all of these structural findings in our body, and it doesn't correlate to somebody's experience with their symptoms. And endometriosis is no different from that. It to your point in that episode, like it really kind of pisses people off. It's tough to talk about this with people because it seems invalidating to their experience with their symptoms. And I think you and I need to let people know we're not talking about it from the medical standpoint. We are not anti-medical. Like, make sure you rule out this. Make sure you rule out all of these things. If I'm not anti-medical in terms of getting surgery, if that's what's, because there are people who I can get them so far and support their nervous system and that sort of thing, and then they go get the surgery and then they're more optimized for their recovery. That has been proven in the research, actually. So we can see in people with endometriosis, this is proven outside of endometriosis, but even more exciting when I read it with endometriosis. If somebody is, and we can screen for sensitization using a validated questionnaire and some of the other symptoms, if like that fit criteria, right? If they have sensitization and neuroplastic contributors, that because there's always going to be overlap to their pain, and then they go have surgery, they are more likely to come out and still have pain because you can't cut out the sensitization. Now, if the symptoms were mostly because of the endometriosis and the sensitization was because of that, plus they also the belief that, I know this sounds crazy, but it's proven, so it is what it is. If you believe the surgery is going to be really helpful and it's driving a lot of the sensitization, and you get that taken out surgically, and afterwards the sensitization starts to go down, then they will do better. But for some people, they still have pain after surgery, or they're better for like 3 months and then they have pain come back. They're thinking it's because the endometriosis has come back. Very unlikely if you've been with a MIGS trained excision surgeon. Sometimes it does grow, but usually not within 3 to 6 months. Okay. So that pain, you have to look at what are the other drivers to pain. Pain is not just a tissue issue. Never. It never is a tissue issue alone. And I think if we learned this in kindergarten, oh my God, like we would be so much better off.
Different people.
Right? So that we know is researched. So if they come to me, I screen for that sensitization. I say, okay, this is a component to it. Let's see if we can optimize your system so that when you come out of the surgery, you're just having to recover from the surgery. You're not trying to recover your nervous system and everything. That's a lot, right? So that's where we're blessed in Canada with a big waiting line of months and months and maybe a year to get surgery.
That's insane, honestly.
I
Like,
know.
I I don't have a solution for that, obviously. It's just, well, let's just bitch about it for a second. That
Yeah.
sucks.
It does suck. I mean, it is good that it is covered under our, taxes and stuff, but that part is nice. Both of our systems are not ideal. Let's just put it that way.
No. Is there a perfect system out there? I don't know.
Not in our countries.
Maybe somewhere in the world.
Yeah. Yeah.
Okay.
I forgot what the
Did
question
you?
was.
Yeah,
I don't
no,
know if
you're
I
good.
answered it.
I think you did. I was just thinking about like bladder endo specifically because
Mm,
there's people that get diagnosed with IC or OAB and then turns out they had endo and then some people are like, well, was it endo the whole time or do I also have IC? Like Lily Reinhart, the actress, just came out like a year ago saying she got diagnosed with IC and this year she came out saying she was diagnosed with endo and it's like, okay. Was that the reason for your symptoms the whole time? And we take that IC diagnosis back now? Like, I'd love to hear your
yeah.
thoughts.
Well, definitely a lot of overlap in symptoms, right? Like people might get bladder symptoms along with period pain, along with maybe it's painful bowel movements. Like there's a lot of symptoms that kind of can overlap with other diagnoses. Um, Bladder pain syndrome, which is what they're really leaning towards calling it. It's funny, I don't think we call it IC in Canada anymore. And I know in Europe they don't, but I know you're also trying to use the word that people can relate to. So I get it as well. But
Exactly.
um yeah, I know. I know you. I got ya. So the fact is, okay, I'm going to say the study, the fact, and then I'm going to say a caveat. The fact is 70% of people with endometriosis have bladder symptoms. So whether that's frequency, urgency, pain with filling the bladder, pain on release of the bladder, or sort of this after the bladder releases, this sort of hangover, achiness, pain, any variation of those. So 70% of people with endometriosis, but only
That is interesting. Mhm. Yeah. Whenever I think of that graph, I don't even know what do you call that picture of like that looking at that image just like stresses me out. I don't know what it is. I think my brain just doesn't it's not comprehending it. Like I can understand it after staring at it for 5 minutes, but at first I'm like, oh my God, what's going on here? It does. It does. Everyone's gonna have to just look it up because I can't even describe this to you. But kind of like recalibrating. Yeah, that's cool. Okay. Well, we're getting to the end here. I'm just thinking, is there anything else that you wanted to bring up to my audience or anything about your story that helped you that you wanted to share? Yeah. Yeah. And goes to show, like, I feel like what I know about endo is it's like a chronic illness, but when you told me that you are symptom free, I was like, holy shit, I didn't know you could do that. So I'm glad you're sharing your story and giving hope to lots of people all day. Oh, yeah. Love that. All right. So, I'm gonna link all your socials in the notes, but do you want to share anything that you're offering right now if someone wants to work with you? All right, amazing. Well, thanks so much for coming and sharing your story and your expertise, Jill. This has been really fun. All right.